Thanks. My name is Marc Gillinov. I'm a heart surgeon at the Cleveland Clinic. I got interested in this topic on a summer night in 1999. A friend of mine who had trained with me, actually he was still training at Johns Hopkins, called me up and said, "Hey man, what are you doing?" And I said, "I'm sitting in the ICU at the Cleveland Clinic. I'm in G54, which is the name of the unit, and I'm trying to take care of this patient I operated on this morning." And he said, "You're an attending now. You should be home. It's summer. It's July. You should have a Heineken, and you should be grilling some steaks, because I'm still a resident. That's my job." I said, "Well, it's not quite like that here." He says, "So what's the problem? Why are you're a newly minted attending, you should be having fun. Why are you in the hospital? Why are you in the ICU in the middle of the night, or soon to be middle of the night?" And I said, "I can't figure out if this guy is bleeding. This guy I operated on this morning, I don't know if he's bleeding. He was bleeding, or let's say his chest tubes were draining 200, 300 an hour for about 4 hours. Then they stopped. They stopped draining. And initially I thought, that's really good. He stopped bleeding. We gave him platelets, we gave him FFP, whatever was wrong is not wrong anymore. Then his blood pressure started to get a little soft, and we started to give him some fluid. And then someone said, let's get an echo, which the usual thing with an echo at this point is it's indeterminate. The echo is not the way to deduce tamponade or not. So I said, I'm sitting here trying to figure out, is the guy bleeding? Is he hypotensive because he's tamponaded? Are his tubes clotted? And he said, wow, 9 years of training, 4 years of college, 4 years of medical school, and you can't figure out if a hose inside a person is open or not. We are pathetic. And he was right at the time. A lot of my colleagues and like surgeons everywhere would say, oh yeah, I don't have that complication. Well, we all actually do have that complication. And that was the impetus to say, this cannot be that big a problem. I mean, they're hollow tubes. Let's turn it into a system that stays open. So here's what it looks like. This is an active clearance technology. This is not a chest tube. It is a system that makes a person drain. It is a chest tube with extra things that make it drain, something to floss it out. And we did realize what I did with this patient that night was I went up to the bedside, I laid down some blue chucks. Have you seen anyone do this? I sprayed betadine all over the place, made a huge mess. Then I put on some gloves, pretending that now it was all sterile. I broke the seal of the chest tube. I took a several $100 Fogarty catheter. I ran it up and down thinking, gosh, I hope I don't hit a bypass graft or something, but I don't know how long the tubes are. But let's cross our fingers and hope it goes all right. I pulled out some clot, and I thought, I wonder if that's all. So I did it for a few more minutes. And then the patient did okay. Then he didn't even get an infection from my violating principles of sterility. And we say, wow, the solution we've got today to a problem that we haven't solved, not so good. Let's just solve the problem. So here is the solution. You see there is a chest tube in the person, but attached to that, between the chest tube and the drainage canister, is the system that keeps it open. And here's what the system looks like. You've got inside the tube on the bottom a guide wire. Think of it as a flossing element. It's almost like it's a roto-rooter. I mean, we could have stolen this from the roto-rooter company, but fortunately they didn't have the patent. And we do. And you just run this roto-rooter-like thing up and down the tube. It's got a little pigtail on it, and it just morcellates clot so that it gets sucked out very easily. Let me go back one sec. I want to show this. The thing that is sort of magical about it is the way we move this pigtail up and down through the tube is by a magnet. At the end of this pigtail catheter is a magnet that we can run it up the tube, run it down, and it flosses the tube out. It lets the pigtail and the guide wire go in and out, and it's of such a length that you can't put it past the exit of the tube, meaning you can't encounter the heart or a graft or a valve or anything like that. It stays inside the tube and flosses it out. And this means I don't have to break sterility, or you don't have to break sterility to do it. It's all integrated. And it works. You just clear the tube. When you try to milk the tube or tap the tube or do something at the skin edge, the usual way, you might be able to clear the part of the tube you can see, but what Ed just showed you is most of the cut is actually on the inside. It's the part you can see. So this gives me the assurance that the tube is clear, it's doing its job. So does it work? I mean, it's a pretty obvious concept. Of course it works. We did it in animals, it worked great, but there aren't a lot of pigs who need heart surgery. If there are, we've got a solution for them, but there are a lot of people who need heart surgery. So for standard heart surgery, this study that you've heard about a little bit looked at people having bypass surgery, valve surgery, bypass plus valve surgery, and the center looked at their baseline data using standard chest tubes, and then looked at 256 consecutive patients treated with the chest drainage system from PluriFlow. So the PluriFlow system that's designed to keep the tubes patent. And here you see what happened. In phase 0, which is in the standard treatment, versus phase 2, which is when the integrated active chest drainage system was instituted, you see in the red, decrease in interventions for retained blood syndrome, RBS retained blood syndrome. Basically, what does that mean? Decrease in interventions to get blood out of the chest, like draining pleural effusions, pericardial effusions, reoperation for bleeding. That went down 43%. And interestingly, post-op AFib was less in people with active chest tube technology or active clearance. This was initially a little bit surprising. Like, why would post-op AFib go down? And I was talking with Ralph Damiano about this, and I said, we find that when we have better drainage of blood from the pericardial space, we have less post-op AFib by quite a bit. It's a big noticeable reduction, statistically significant in everything. And he said, well, of course, that's obvious. One of the models we use in the lab is we take animals, put blood in the pericardial space, close it up, and they get AFib because blood is inflammatory. And if you leave blood on the heart, you're more likely to get AFib. You drain the blood, you're less likely to get AFib. And they said, how come you didn't know this? I said, I don't know, but I'm glad that you could explain it, because now we do know it. So I can tell you, that's from Ralph Damiano, who's smarter than I am. If we look at patients, that was in all comers, regular heart surgery, and it worked, it was great. What about the people who you know are going to bleed? Ventricular assist device patients. These patients, they're almost all redos, they're anticoagulated. These guys are gonna bleed. And if you look at two different devices, two different types of VAD or ventricular assist device, they tend to have most of their bleeding the first 3 days. And if you look at the axis, the y-axis, it's a lot of bleeding. You know, we're talking a liter plus. And the question was, what do we get in these patients if we have active clearance technology? And here's the answer. If we look at people having standard drainage versus active drainage with PluriFlow, we have a substantial reduction in interventions for RBS or retained blood syndrome, 39% reduction, fewer re-expirations for bleeding, and less need for delayed sternal closure. These redo patients getting ventricular assist devices, they often bleed so much you have to leave the chest open. But if you know you can drain the blood, you can close the chest, which is a huge benefit because infection is one of the huge life-threatening enemies of VAD placement, and this lets you close the chest. If you do an analysis, that was raw data. If you then adjust for confounding factors and match the patients, you get the same thing. Active clearance technology reduces reoperations for bleeding, lets you close the chest earlier, and also avoids the need to place a new chest tube later on. Oftentimes, if you don't have good drainage initially, you have to place a new chest tube later. If you use PluriFlow initially, you're good to go. No new chest tubes. So I showed you two different scenarios with data. Regular patients, good results. Very complex patients who are going to bleed, also good results. That raises the question, which we're often asked is, so when should I use this? Should I just use it if I know I'm going to have bleeding, or should I use it in everyone? And a reasonable analogy is this. We wear a seatbelt all the time because we want to be ready just in case something bad happens. Do you want to be ready and be protected? Most importantly, do you want to be protected all the time, or do you want to wait for a fire and make sure you've got a fire extinguisher near you? Meaning, do you want to wait for the problem, wait for the disaster, and then try to recover? And of course, the seatbelt analogy works. You want to be ready, you want to be prepared, you want to avoid the problem. Don't let a fire start. Second question that comes up after when is, what about the money? medical devices, medical care, you've heard, big part of our GDP. This costs money, but actually this saves money. This is a small investment to save a lot of money because the complication caused by retained blood, whether it's draining of pleural effusion, pericardiocentesis, back to the OR, reoperation for bleeding. Bill Clinton with his decortication, which I understand was, one of my friends did that operation. He said it was a miserable, terrible operation. The only thing good for him was he wasn't the guy having it, who was Bill Clinton. So these things are not only personally costing to the patient, they cost a lot of money, and preventing them saves money. So if you look to your left, if you're in a hospital that does 1,200 cases per year, you'd expect about 17%, 200 of those 1,200 people, 200 patients, are going to require some kind of drainage procedure for retained blood. And that's going to be very expensive, millions of dollars. If you had reduced the need for these procedures by active clearance technology, if you had put in the right chest drainage system, the best chest drainage system at the beginning, you would prevent about 42% of these, and you would actually save millions of dollars. So we're judged really in medicine by two things: how the patients do and how much money do we either spend or save. This checks out just right on both ends. Patients do better, and we save a lot of money by avoiding complications. And increasingly now, across the map, this is a map of the US, a little faded, but more and more centers are saying, yeah, this makes a lot of sense. Better outcomes, less spending, that's something we all like. This is not just a single person doing it, though. I mean, I place the chest tube in the OR with the PAs in the OR, but then the nurses in the ICU are the ones who are making sure they work, and they actually like doing that a whole lot more. Just run it up, run it back, push the magnet in, clean the tube, pull it back, good to go. They like that a lot more than trying to page the resident on call and find some guy who doesn't want to come to clear the chest tube. So way better that way, but it is the whole team, and it makes sense for everyone. And it's going to become increasingly important as we're under the threat of new payment systems. And basically what is going to happen, starting with the data from the coming year, programs that have fewer complications will be economically rewarded, and they will be rewarded by taking money from programs that have more complications. Programs that have more pleural effusions, pericardial effusions, reoperations for bleeding, decortications for fibrothorax, they're all going to be penalized, and that money will be given to the programs that had fewer complications. And it's going to increase year over year with the data being collected this coming year. So that's further impetus. If it weren't enough to say I want to do the best thing for my patient, it's going to be the best thing for the whole program, and it's going to keep us solvent to do it right. So we all have choices. Who should get this? All versus selective? I use it in all. Because if I were the one having surgery, on a personal level, if it were me, I want all the blood drained out of my chest. I don't want a complication. Active chest drainage, it just works better. When should you do it? We tend to leave the tubes in for a day. If somebody continues to drain, even if it's that clear fluid that you might see post-op day 1 or 2, if they're draining 50 cc's an hour, I'm going to leave it in another day, because that will prevent me having to sit them up, do an ultrasound, and put a needle in their back to drain the pleural fluid, which no one likes. Why do it? It improves the quality and saves money. And how? I mean, we do it every day. On Monday morning when I'm in the OR, I will be placing these tubes because it's going to make my patients do better. It's going to prevent complications. And I'm particularly enthusiastic about it reducing the incidence of post-op AFib, because that is such a nuisance. And anytime I can spare the patient and me and my team from post-op AFib, that's a good thing. Thank you.